Good evening. The next session is a virtual session. The speaker is Dr. Nasreen AlSayed from Bahrain. She is the chair of Africa and Middle East Regional Federation for the International Atherosclerosis Society, and she is the chief medical officer at Dar Al Saham Medical Center. Uh, an endocrinologist and a clinical lipidologist. So the topic for today's session is LDL cholesterol lowering in diabetes and how low should we go.
Hello, everyone. Thank you very much for the kind introduction. I would like to thank the organizing committee for inviting me to give this talk in this year's program as well. Unfortunately, I was not able to join you physically due to travel commitments. It is always a great pleasure to be with you. And I'm grateful that I was able to give you this talk virtually, and I hope you find this talk interesting and fruitful. So I'm going to talk about LDL lowering, how low should we go? I think this topic it's very, very important and vital. This talk isn't just about the science of hitting LDL targets, it's about the art of consultation. So we are currently competing with the flood of online misinformation that claims LDL doesn't matter. I hope to provide you with a framework to debunk those myths and strengthen the shared decision-making process in your practice. These are my disclosures. So to start with, these are the learning objectives for the talk. We're going to cover the role of LDL cholesterol in cardiovascular disease, followed by the role of LPA lowering therapy for pharmacotherapies, current guidelines on lipid management and targets, recent trial data on lowering LDL cholesterol and the effect on CVD, and finally, safety considerations of lowering lipid levels. So to start with, I'm sure most of you know the role of LDL and how the LDL cholesterol and how it plays a key role in plaque formation and atherosclerosis. So you start with endothelial dysfunction due to any stressor factors that lead to LDL retention and modification in the arterial wall. Then the modified LDL triggers inflammation and monocyte recruitment and the release of the reactive oxygen species and radicals and forming the foam cells that sustain vascular inflammation and drive plaque development, and thereby after the plaque development you could have possibly the plaque rupture and then consequently the cardiovascular event. So LDL plays a primary role in that. Now, when we look at how we can tackle the LDL cholesterol, thankfully we have a lot of options in terms of pharmacotherapy and lowering the LDL cholesterol. So we have different types of statins ranging from, moderate intensity to high intensity statin to ezetimibe. Now we have the bempedoic acid, we have the monoclonal antibodies, the PCSK9 inhibitors, and the siRNA PCSK9 inhibitors. So we have a bunch of pharmacotherapies that in monotherapy or in combination, you can cause really significant LDL lowering. So some combination therapies, as you can see from this slide, you can lower LDL cholesterol anywhere between as high as 70 to 85% reduction from baseline when you have really the ideal combination therapy. Now, despite all that, and specifically looking at statin trials, and these are all the popular statin trials that I'm showing you over here, we can see that there is still residual cardiovascular risk remains in these trials. due to multiple other risk co-founders. But again, despite all these residual risks, still most of these several studies that were conducted using statin therapies, the popular ones, showed that there is a lower risk of cardiovascular events whenever we lower the LDL cholesterol level. And when we talk about cardiovascular events in these statin trials, for example, you have the HPS, CARE, and lipid trial. The cardiovascular outcome that they examined was death from coronary heart disease and non-fatal MI, while in 4S and TNT, it also included resuscitation after cardiac arrest. So we know that when these trials, again, achieving lower LDL cholesterol was associated with positive outcome, cardiovascular outcome. Not only that, this is a beautiful graph that I would like to always use in my, discussion on when there is any time argument about, the role of LDL cholesterol as a causation of cardiovascular disease. We have clinical evidence in terms of pharmacologically lowering LDL and how it is associated with lower coronary heart disease or cardiovascular events. But equally important, we have also evidence from genetically lower LDL cholesterol levels associated with lower risk of heart disease or cardiovascular events. So these are people who are born with genetically very low LDL, and these people were at lower risk of cardiovascular disease. So this is an evidence from nature that we have in these populations, showing the importance of or the link between the LDL cholesterol and cardiovascular disease. So with every major LDL cholesterol trial showing the incremental benefit from lower levels, the question is no longer if we should lower LDL cholesterol, but how low should we go? That is really the question. So looking at the American different guidelines, starting with the American Heart Association, American College of Cardiology 2018 guidelines, you can see that there are no strict targets in terms of targets or attaining certain levels of LDL in certain risk groups. So in this guideline, you have patients sort of stratified into low, medium, and high risk group. But what really the guidance is here that they give you the threshold at which you should be considering lipid lowering therapy. So they're talking about in milligrams, 70 milligram per deciliter LDL and above. That would be the set of your LDL threshold to consider lipid lowering therapy. But they talk about percent reduction in LDL cholesterol from baseline. So for the intermediate risk group, they recommend 30 to 49% reduction in LDL from baseline, while for the high risk group, they are recommending more than 50% LDL reduction. So again, it's a bit confusing because you don't have a clear target in these different risk populations. While looking at the European guidelines, so the ESC and the EAS guidelines was updated recently, probably most of you know. So the 2019 guideline was updated in 2025, and now as you can see, we have an addition of the extreme risk group, which was not there before. So the extreme risk group include patients with recurrent cardiovascular disease or patients with polyvascular disease, like for example someone having coronary artery disease as well as peripheral vascular disease. And look at the target set for this group, the LDL, and they have given it class 2B. So the LDL could be as low as below 1 millimole per liter in these extreme risk patients, while the very high risk maintained its its previous target, which is below 1.4 millimole, and the high risk group is below 1.8 millimole LDL, and the moderate is below 2.6, while the low risk is below 3 millimoles. So this was the updated version, which include the extreme risk group and setting up really, really aggressive targets. Now, if we compare, I've showed you the American College of Cardiology, the European Society guideline, and now we come to the Middle East guideline. And this is the guideline that we have published back in 2021. In our guideline, we have already set the extreme group even prior to the recent update from the European guideline. So we do have the extreme group, the very high, and the moderate and low risk groups. So the extreme group in our guidelines are all patients with diabetes, familial hypercholesterolemia, who have evidence of established cardiovascular disease, so they are automatically in the extreme group, or patients with established cardiovascular disease and recurrent cardiovascular events or polyvascular disease. So these fall in the extreme group. So our target is not as aggressive as the European, but you never know, maybe in the updated our updated guideline, we might consider more strict targets. But here for the extreme group, we recommend LDL cholesterol below 1.4. Additionally, if you note from our guideline, we are not just focusing on the LDL, but we're looking at non-HDL and ApoB as well. So in these patients, the extreme, we want the non-HDL below 2.2, the ApoB below 65, and in terms of the very high and high risk group, we are setting the same LDL targets, which is below 1.8 millimole, and for the moderate, which should be below 2.6 millimole, and for the low risk below 3.4 millimole. So these are the risk stratification groups so as you can see, patients with established cardiovascular disease, they are in the extreme, which is the red arrow. The yellow arrow represents diabetic patients. So if your diabetic patient is with established cardiovascular risk, would be in the extreme. Diabetic patient with other 1 or 2 risk factor would be in the very high, and diabetic patient without any other risk factors is already in the high. So any patient with diabetes is either in the high, very high, or extreme risk based on their cardiovascular profile and risk factors. While the blue arrow represents patients with familial hypercholesterolemia, and that follows the same rule with the diabetes patients. Now, if we want to examine and see in real life how these targets or guidelines or the different LDL targets would be the ideal to follow. I mean, is it the American guideline, the European guideline, or for example, the Middle Eastern guideline? But this is a simulation study from the Da Vinci cohort. So this is a study where they looked at more than 2,000 patients with established cardiovascular disease. 23% of them had CAD, 37% had cerebrovascular disease, and 40% had peripheral artery disease. And when they look at this pool of data, they have applied the American guideline, which is here in the orange section, as you can see. So, LDL below 70 milligram per deciliter, while in the middle one is following the previous European guidelines, which is similar to the Middle Eastern guideline, LDL below 55 milligram per deciliter, and the yellow one is really the extreme target, which is below 40 milligram per deciliter. So you can see at the bottom here the relative and the absolute risk reduction. So if you follow the sort of more flexible target, you're still giving the patient some benefit, but this is like 14% relative risk reduction and absolute risk reduction 4%, versus if you go more aggressive, this is a further reduction, 22% relative risk reduction and absolute 6%. And if you go even lower, the relative risk reduction is even Fascinating. It's like 29%, and the absolute risk is about 8%. So the lower we go, the lower is the risk of adverse cardiovascular outcome. And this is another evidence to support the lower LDL in these high risk established cardiovascular patients is very important. Again, another evidence, a meta-analysis of 26 studies demonstrated that linear risk reduction of MACE with lower LDL. So for each 1 millimole or 39 milligram per deciliter, it results in about 22% relative risk reduction in MACE. Again, we have evidence from different pharmacological trials. Improve It trial was one of their landmark trials in cardiovascular disease. In this trial, they have compared simvastatin monotherapy versus simvastatin ezetimibe, because this combination resulted in more effective and more LDL lowering. So the LDL level in this trial actually reached as low as 50 milligram per deciliter. And you can see that there was no early separation of the curve, but the result or the effect was profoundly seen in 7 years. It is true that it took some time, but again, it shows the legacy effect of this combination therapy that resulted over 7 years of 6.4% absolute risk reduction. Another evidence, that one was a ezetimibe statin combination. These are the evidences from the PCSK9 inhibitor trials. So most of you know about the 4-year trial, and 4-year evolocumab added to statin versus placebo showed again 15% relative risk reduction in cardiovascular events over a median of 2.2 years. So even a shorter period of time, there was a significant difference. Similarly, in the same group, the PCSK9 inhibitors, we have seen in the Odyssey trial, again, the benefit of adding alirocumab post-ACS, and it provided lower LDL levels that led to about 15% relative risk reduction in MACE at 3 years period. Another important outcome trial was the CLEAR outcome study. Now, in CLEAR outcome study, bempedoic acid. Bempedoic acid is an inhibitor of cholesterol synthesis in a pathway that precedes the HMG-CoA reductase, where statin is working at. So again, it's one of the really important lipid-lowering therapies. Unfortunately, we don't have it available in Bahrain, but it is available in some Gulf countries. Bempedoic acid, if it was used in statin-intolerant patient, it achieved 21% reduction in this trial, and it also had cardiovascular benefits. So there was a 13% decrease in major cardiovascular events, again confirming the lower we go with LDL, the better would be the outcome. We have important trials in the cardiovascular, not only on the relationship between LDL lowering and cardiovascular outcome in terms of MACE or cardiovascular death, but also in the regression of the coronary atherosclerosis. So for example, Astrio trial is one of the landmark trials where they use the high intensity rosuvastatin, and it showed that there is a regression of the atheroma volume. Similarly, in Glagov trial, where they compared evolocumab with the controlled group, and there was a 64% plague regression with evolocumab. Again, reversal trial where atorvastatin was compared with pravastatin. Again, because atorvastatin is a more powerful statin compared to pravastatin, it achieved atheroma volume regression in these patients. So not only cardiovascular benefit, but also regression of atheroma volume and coronary atherosclerosis. So Despite the safety concerns, and we do see that a lot over social media, and this is like the number one obstacle that you face in your clinical practice when you want to start your patients on lipid lowering therapy, especially statins. There was no adverse events from several studies reported, even if you go as low as LDL cholesterol of 20 milligram per deciliter. I call it infantile, cholesterol level. So an infant who is going through a period of growth, and especially the massive growth that happens in the neurons and the cells of the brain, the infant is starting at a very low LDL cholesterol. And similarly here, what you're achieving, you're preventing adverse cardiovascular outcome without any major concern. Actually, when you achieve very low LDL cholesterol level, there is an extreme, you're kind of protecting any chances of hemorrhagic stroke, or the hemorrhagic stroke would be even lower in these instances. So there were no safety concerns whatsoever in terms these neurocognitive effects or liver enzyme elevation or CK elevation. So if you look at the purple bars compared to other colors, the purple bar is like extremely low LDL, which is below 20. There were no statistically significant difference. Again, a meta-analysis of key trials. We're talking about really important trials, all demonstrated that very low LDL cholesterol levels do not increase adverse events or discontinuation. And again, lowering LDL cholesterol levels beyond current targets is actually associated with further reduced cardiovascular risk with no offsetting safety signs. So we're talking here about, now if you look at this, you're looking at patients with event numbers. So you can see on the left here the experimental arm, and then the control arm, and then the meta-analysis data. You can see that if you compare the numbers in terms of myalgias or myopathy, aminotransferase elevation, new onset diabetes, hemorrhagic stroke, cancer, there was no statistically significant differences. And it's very important when you see in your clinical practice, especially with the myalgias and the myopathies, it's very important you make sure they fit the criteria. And actually, this is not my talk today, but they fit the criteria of classic statin related, which is not very common, and it is not the nocebo effect. So the nocebo effect, we see it in patients coming to you because they hear that on the social media and they believe that these medication definitely are the cause of their myalgias or whatever, or the side effects, but it is most likely it's just the psychological belief that these medication would cause these adverse events. So finally, I would like to come to the last slide to conclude about the importance of this talk, which is related to LDL cholesterol lowering and the targets. As you have seen from the different guidelines, LDL contributes to atherosclerosis and increased cardiovascular risk. Lowering LDL cholesterol linearly reduces the risk of cardiovascular disease. Key trials have demonstrated that very low levels of LDL cholesterol actively regresses coronary atherosclerosis. Very low levels of LDL do not cause an increased safety risk. And then finally, failure to reach LDL targets is largely driven by clinical inertia and safety concerns, necessitating a more aggressive treatment to meet guideline mandated goals for extreme, very high, and high risk patients. And with that, I would like to conclude my talk. Thank you very much for your attention.